It's Friday, October 17th, 2025. Welcome to Make It Make Sense. I'm Granthermes. Today marks 16 days of the government being shut down. And every day the government is shut down is a day closer to a crucial expiration date for healthcare subsidies and access to healthcare for millions of Americans. It's actually really why the government is shut down right now. Democrats want to extend certain Affordable Care Act and Medicaid tax credits and subsidies, and Republicans want to deal with that in December, but well past when those subsidies expire. It's why my guest today is assistant professor from the University of Michigan's School of Public Health, Michael Shepard. And I talked to Shepard about what he focuses on, which is rural communities and their health care. Because, yes, when these tax credits expire and if nothing is done, it's going to be bad for a lot of people. But it's going to feel worst in those rural communities, in places where hospitals are tens, maybe hundreds of miles away, depending on which state you live in or how big the state is. Maybe that hospital is the only one in your area. Usually those hospitals are the centers of jobs in those communities, generally small towns filled with doctors and nurses and healthcare providers and administrators. And what happens then if these hospitals aren't propped up by these tax credits and can't serve the communities that they're in? Shepard and I talk all about the consequences of that and what we're hearing right now from members of Congress, mostly Republicans, who represent these places but don't seem to care about what'll happen to the health care in their districts. But before we get to that, make sure that you're following or subscribe to the show on whatever app you listen to it on. Like, subscribe, hit the bell for notifications, and leave a comment below if you're a watcher on YouTube. Sign up for the Make It Make Sense Substack, where I've got a brand new newsletter dropping today that'll be out every single Friday for free subscribers called TLTO, or Too Long Tuned Out. If you're a longtime listener, you'll remember that used to be a part of the podcast every Friday. That fell by the wayside as things shifted and changed here, but I'm bringing it back in this newsletter. It's a weekly roundup of all things Make It Make Sense, the podcast episodes you might have missed, the weekly original reporting that you'll get if you're a paid subscriber, plus the social media extras, and a little bit about how I'm keeping myself sane right now as the world is as crazy as it is. And as always, share the show on social media. It's Mims News Pod. That's MIMS News Pod, all one word on every platform. I am at Granthermes on Twitter and Bluesky, and at Granthermes TV on everything else. All right, let's get to the show. Today's episode is brought to you by Distill Union. Founded in 2011, Distill Union crafts everyday essentials like wallets, key organizers, phone cases, and stands, believing that less is more makes good design. They've earned a reputation for creating problem-solving products that are both intuitive and elegant. I like their flagship Wally wallet because, you know, there's nothing worse than having that bulky wallet that sits in your back pocket for guys specifically. It's bad for my back. I can feel it after I've been sitting, especially on the chair that I use to record in here. It's not exactly the most comfortable chair, and if I've got my wallet on me, it's uncomfortable if it's not slim and elegant like their Wally wallets. But they're known for their magnetic closures and that slim profile to hold all of my cards and cash. I love them. And they just launched a Kickstarter for brand new MagLock belts. I don't know exactly what that means, but it kind of sounds cool as hell. Anyway, Distill Union's problem-solving accessories are made from premium materials like full-grain leather that ages beautifully over time, ensuring durability and style. Backed by a 3-year warranty, their products are built to last and engineered for everyday ease, offering the perfect balance of practicality and sophistication. And right now, when you use the code MIMS25, that's MIMS25, you'll get 20% off your entire order. And Make It Make Sense does get a cut of that sale, but hey, it keeps the show going, keeps you in style. What's not to love? You can check out DistillUnion.com for all their great products. That's DISTIL Union.com. Distill Union, where good design is good for you. All right, let's get back to the show. Michael, thank you so much for being here. I really appreciate it.
Yeah, thank you for having me. I'm looking forward to it.
So let's start with the government shutdown right now. Ostensibly, this is happening because the Democrats want to extend certain healthcare tax credits, among some other things. Most of those tax credits for Medicaid, for the Affordable Care Act, are going to affect the people that you talk to and study every single day. So walk me through what happens November 1st when these folks no longer have access to a lot of their health care?
Yeah, it's an important question. That sort of what's next, I think, is in some ways easy to square and in other ways very difficult to understand. So I think for virtually every American, you can expect to see your health insurance premiums spike for the next year unless these measures are adopted. The Biden administration expanded tax credits related to the ACA marketplace to make health insurance more purchasable for most American families. As a result, lots more people ended up on the ACA marketplace than we had before. We reached high levels of marketplace utilization over the last year or so. When those premium tax credits expire, essentially those millions of folks are going to have to pay a lot more for their health care. We think for most people, what that means is that they will not buy health care altogether. So most of our evidence suggests that people at that point will just not purchase health care, purchase health insurance, I mean. That's going to have a combined effect, one of which is on all of us, which is that our health care or health insurance costs are going to skyrocket. KFF, Kaiser Family Foundation, estimates that in some places you can expect your health insurance premiums to more than double.
I think they were saying it in Alaska and in other parts of like rural Montana and stuff, it was going to triple.
Yeah.
I think people in Alaska have already been getting those letters.
Yeah, I think that's part of the difficulty of the timeline here is that people are starting now or will be starting soon their open enrollment periods for most of their employers and for the ACA marketplace in general. And so these companies are trying to budget for next year with what seems like a reality is of losing these tax credits. For what it's worth, most of the healthcare professionals that I've spoken with are more concerned about this change than they are about some of the others that have already taken place this year in terms of access and affordability. In part because when people lose their health insurance, they either avoid receiving health care altogether, which is bad for their health long term, or they go to the hospital nearby and consume what we call uncompensated care, which is basically health care that hospitals are required to provide to people, but that no one pays for, right? So that basically gets absorbed within the hospital. Oftentimes that cost is passed on to consumers in other ways, if not a part of the nonprofit hospitals' operations already for being for their tax benefits.
Which is a little twist of irony in this too, because the line that is coming out of the Republican Party right now about the shutdown is that Democrats are doing this to give millions of undocumented immigrants access to Medicaid or the ACA, which they're not eligible for. I've talked about that on the show before for the listeners, but the vice president stood in front of reporters in the briefing room and said Americans don't want to pay for health care for people who aren't Americans, but then we are going to have to do that anyway when these tax credits expire because people will be forced to go to emergency rooms.
Yeah,
right.
It's certainly an attempt to obscure the truth. As you mentioned, undocumented immigrants are not eligible for these funds. These funds are going to working American families to help people who don't make large amounts of money purchase an expensive product, when that being health insurance. When those tax credits go away, we're talking about people who are already working, who are already trying to earn a middle-class living, not being able to afford health insurance. And that's really it. Those effects are particularly large in rural communities where we have folks who are making relatively lower incomes, and as a result, they're more eligible for these programs. So in states with large rural populations that have expanded Medicaid, you're talking about some pretty catastrophic changes as a result of both the potential expiration of these tax credits as well as the changes to the Medicaid program that we observed earlier in the summer. On the provider side of things, that means harder to maintain operations in the long run and potentially hospital closures or provider closures in general. In rural communities, a lot of these places are already operating on a shoestring budget, many of which are not making money to begin with. And so when you blow a gigantic hole in their budget from cutting Medicaid, and then you turn around and they're paying customers, and by paying customers, I mean people that have purchased health insurance over the marketplace, also are not showing up or are showing up without health insurance. You've blown another gigantic hole in their budget, and that does not make for long-term financial sustainability for most of these places.
I don't remember which member of Congress it was, but he was talking, I think it was to CNBC. I saw the clip of it last week, and he basically said that most of these rural hospitals, he didn't believe that the closures were real, for starters there, and you can talk about that for me. But the second thing is he said that if they aren't closing, maybe they'll just have to pare back to the bare minimum of care. And it was sort of a like, shit happens kind of reaction to this thing. And I found it to be really, callous to start off with, but kind of shocking in a way that the language we are seeing now around what's happening to rural healthcare is so naked in that way. They're not really even trying to say, we're doing our best to make sure these things don't close while not really doing that. They're just being like, yeah, this is going to happen. Can you talk me through first the rural hospital closure problem, and then let's talk about the way that the Republican Party is talking about this right now, because they are talking to mostly their voters.
Absolutely. So rural hospital closures are very much real. When we look over the last 15 years or so, there have been roughly 150 rural hospital closures. And by closures, I mean they're not doing anything anymore. They are closed, and in many cases, abandoned buildings. When a rural hospital closes, it has devastating effects on a community. I think most pressing are health-related issues. So from things like strokes and heart attacks to snake bites and gunshot wounds, when your hospital's not there, your healthcare or your health outcomes are going to suffer pretty quickly from emergency situations. And the further you are away from care, the more likely you are to have your health condition suffer more, the longer you have to travel. We also see pretty sizable economic effects, which is that when in many communities, these hospitals are the largest employers. And so when they close, a lot of people lose their jobs. They're often located in places for which there's not sort of a backup hospital close by. And as a result, that causes people to either have to leave the community altogether or seek or drive far distances to get to new jobs, as well as the next available healthcare. Over the past few years, what we've seen is another phenomenon, which is when people lose their local hospital, within the same time frame, they've also lost their next closest hospital due to the same considerations, which makes that distance even further. In terms of like the likelihood of closure into the future, so most of these sort of like nonprofits or research institutes that gather the financial data on hospitals and present them to the public suggest several hundred rural hospitals are already operating on negative margins and are likely have faced risk of closure already. That risk has increased substantially as a result of the changes to the Medicaid program, and will increase even further if these premium tax credits are not expanded, all centering around uncompensated care. That is, that care they're providing and not being paid for. When people don't have Medicaid, they show up at the hospital just as the same as when people don't have health insurance. The hospital has to provide that care. They're not getting reimbursed for it. And as a result, they end up stomaching quite large losses. So it would be unfair to say that the policymaking decisions currently are the only reasons that these hospitals would close. But it would be fair to say that this might be the thing that pushes vulnerable hospitals over the edge. And we've already seen some versions of this. Importantly, it doesn't actually matter that the policy changes haven't taken effect yet, because hospitals are not making decisions on a day-to-day basis. They're evaluating in the long run, right? So when they see next year is going to be even harder to survive, or 2 years harder than that, that's how they're making decisions about closure. In terms of like cutting service lines and consolidating things like that, that is typically the strategy that a hospital will engage with to try to survive. So they'll either shift, if they're a part of a larger system, service lines will be given to particular hospitals rather than available in all hospitals. If they're a solo hospital, they will pull back on providing service lines for things that are not profitable or are less profitable than others, often what that means is like labor and delivery units get closed. Behavioral health service lines are closed. ICU units are closed. And so while you might have an emergency department or you might have a shell of a hospital, you don't have the full range of a hospital in many cases, even if it stays open in that sort of in-between period of trying to financially weather these things. From an economic standpoint, it makes sense that we maybe want many of these things to be located in places where there are a lot of paying customers. But from a health standpoint, it's very much anti-equity and very much anti-health to say we should expect folks to be able to travel long distances for things like childbirth, for things like emergency healthcare needs, or for behavioral health outcomes. And so, while it might be tempting to say, well, they should just cut services to stay open, people depend on those services. And those services are not only going to benefit folks' health, they're also a source of employment in areas in the country where there aren't many middle-class employment options. And so I think saying that one should just get used to that or be comfortable with that, is coming from a position of pretty severe privilege when you're not navigating the healthcare and economic realities of these communities. A lot of places, these hospitals provide the only available sources of primary care, behavioral health services. And so I think it's an unfortunately very large ask to expect folks to drive, in some cases, hours to get to the next available form of care.
And when you're talking about a pregnant mother in a difficult delivery who then has to drive an extra hour, that could cause serious complications for her and the baby. When you're talking about somebody with a gunshot wound or a snake bite, like you said earlier, and I shouldn't laugh at that. That's a real thing that happens. I lived in Oklahoma and Texas. I know that happens. People who have strokes or heart attacks or immediate things that need immediate care, and then they have to drive an extra hour, that's going to cost people their lives. And I think that shouldn't be overlooked here. I don't think that's hyperbolic either to say that. So when you hear the way that these things are being talked about and described to rural voters, and specifically we're talking about from the Republican Party because they do speak most of the time to and for the majority of rural voters in this country, how do you circle the square of how they're behaving right now versus what their voters need?
Well, there's in some ways, for many groups of voters, a mismatch between need and political preferences. For a long time in the U.S., there was a pretty strong correlation between class or vulnerability, including health vulnerability, and how people vote. That doesn't really exist in rural communities. Rural voters of a variety of health considerations, a variety of economic classes, support the Republican Party and trust the Republican Party to do things that benefit them. And benefit them can mean a lot of things, right? So benefit can be something cultural or status-based, or it could be economic-based. And so I think for a lot of rural voters, there's an implicit trust and identification with the Republican Party, a belief that the Republican Party is similar to them socially and culturally, and is doing things to better serve the interests of the community. But what oftentimes sort of in the head of a voter is a sort of combining social considerations, cultural considerations with material ones. It's not that those things are unimportant or ignored. It's that it's really hard for people to know why they feel a certain way about a group of people or of a party. And once they support that party, they take their word for the things that they're offering. And so there's a real hesitation, I think, to blame Republican politicians for policies that are enacted that are harmful for rural communities. But there's also a tendency to reinterpret that harm to be either the fault of the Democratic Party or the fault of sort of non-political forces. And so I think the way I would characterize it is they have good reasons, or they have reasons at least, for supporting the Republican Party more on an identity basis, and that ends up trumping how people feel about things like Medicaid, et cetera. I think part of that is that the changes actually just don't hit them quite yet, and they will eventually. But I think the other part of this is how one interprets their experiences can be pretty complex, and interpreting one's experience through any type of identity can lead us to make conclusions that maybe aren't best backed up by data. So one of the best examples of this is if you ask people how the economy is doing when their party is in the White House, they tend to over-evaluate things as good, and if they're out, over-evaluate how bad things are. And that tends to switch the moment there's a change in power. Yeah. Even when the economic conditions are the same, right? And so that really suggests that when you have that identity affiliation with some group, in this case, rural voters for the Republican Party, how you evaluate the world around you is really shaped through that identity, as opposed to sort of weighing the objective indicators on the ground. And important ways that kind of lead or shield the Republican Party at an elite level from being blamed for a lot of these things. So I think for most of these folks, people in general, it's not just rural people, aren't paying a whole lot of attention to politics right now. Yeah. And they experience life in a variety of different ways. And when bad things happen, sometimes they look for people to blame. And if they're given a useful framework from politicians they trust, that's the one they adopt, even if that's not the correct one.
When we talk about people losing those tax credits and subsidies on November 1st, and that will cause a lot of people to have to move off their health insurance. I think Marjorie Taylor Greene, the representative from Georgia, was talking about how several thousand of her constituents in just her district were saying that they were going to lose their health insurance, and she was sort of caught unawares of that being a thing that might happen to her district. What do we know about when people lose their health insurance? How many people come back? Because there's an interesting piece of this where the Speaker of the House, Mike Johnson, has continued to say that they wanted to deal with the healthcare portion of what was happening in the government after November 1st. In December is what he was saying, more than a month after these things would have expired. What do we know about how people come back to health insurance? I would imagine that it's difficult because there's so much paperwork to get through that fewer people get coverage again.
There's certainly a stickiness to this. So once someone loses coverage, they tend to experience a series of bad outcomes afterward that make it harder for them to fully come back. So if you're losing your access to healthcare because it's too expensive, unless there's a policy remedy to make it more affordable in the short to medium term, highly unlikely that you're suddenly going to be able to afford it anytime soon. But you also have to deal with the fact that for folks who have to utilize healthcare in that interim, we're talking about pretty steep increases in their out-of-pocket healthcare costs, which can put them in a more vulnerable financial situation than they were at the start of all of this, sending some of this spiraling, right? Where this outcome that leads people to lose their access leads them to make financial decisions that are tough ones that put them in worse financial position, making it more difficult for them to recover either financially or to receive health insurance again in the future. It's not as if this is like a permanent removal. Many folks will find ways to navigate the situation. Sometimes what this leads to is people's income spiraling such that they shift from being in the marketplace to being eligible for traditional Medicaid. Oftentimes, employers will engage in a variety of different health insurance decisions that maybe make things somewhat accessible for folks, even if it's not at the same level as before. But oftentimes, at least in that short to medium term, what we're talking about are spiraling bad outcomes for people who already aren't in the most advantageous economic position. It's highly unlikely without some type of policy change that these folks will be able to purchase health insurance. Instead, what we'll see, or maybe some people can, but we will likely return to somewhat of the state that we observed prior to the Affordable Care Act, which was 15 to 20% percentages of people that lack health insurance across
we're
most of
talking
the
tens of
country. In some
millions of
places, a
people
lot higher
who
than
don't have
that.
health insurance.
Absolutely. And by the time you sort of layer on the Medicaid work requirements that are also being enacted roughly around this same time, we're talking about millions of people who are likely to lose access to their health insurance, either because they no longer can afford it or because navigating the paperwork elements of the work requirements prove to be too difficult to navigate. That will have a lot of downstream effects on the healthcare system. It's going to make it harder for providers to stay open. It's going to make healthcare more expensive for the people who are fortunate enough to have health insurance. People who have health insurance are going to be paying a whole lot more for it. And that has a variety of downstream economic effects. That's less money you can spend on other things, right? And so I think we sort of oftentimes boil down the effects of a health policy on health outcomes or a health policy decision on health spending outcomes and don't fully appreciate this will reverberate throughout the economy, perhaps especially in working class and in rural communities where people's disposable income is considerably smaller.
Do you think that we are heading towards a push to remove the duty of care from hospitals? That law is, 41-ish years old, 39 years old? Are we heading to a place in which hospitals can no longer care for people because there's just not the money to back them there? And do you think there's going to be a push for that in Congress?
I haven't heard anything related to that, although that is often mentioned as a source of financial hardship for some of these hospitals.
Mm-hmm.
My sense is that the providers would be more inclined to push for some type of reimbursement scheme for uncompensated care as opposed to not having to provide it at all. I think they'd rather be paid for providing it as opposed to not provide it. So I don't see a push coming from the provider side of things. EMTALA, which the duty to care law comes from, is actually enacted somewhat in a fluky situation. It didn't actually get a lot of attention at the time, but it has had tremendous effects. So I could see a world where there's a push to have a rebate system so that care is no longer uncompensated in some pure sense. But speaking more editorially and more of an opinion based, I certainly hope not, because I think that would have pretty catastrophic effects on people's health.
The last thing here is, how do we pull ourselves out of this spiral for rural Americans, for the rural hospital systems we have? Because it just doesn't seem like we are anywhere close to being out of the woods on this one. So how do we get there?
It's a great question. I think at this point, states need to really be thinking about investing more resources in their healthcare systems, especially in rural health. I think the investment in preventative health measures is also going to be pretty critical to keep people out of the hospital so that we don't have these problems. I think the ultimate answer is more resources across the board, and I don't necessarily see that as an easy solution. Rural healthcare is not something that's particularly profitable, and I think we really have to wrestle with, as a country, as states, what do we do with things that provide important resources or important services that aren't profitable? And so long as we view healthcare as something that should be profitable, the rural parts of the country are always going to end up on the losing end of the stick. And so I think subsidizing rural healthcare from the state, from the federal government, in more substantial ways than we already do would be helpful. I think the most likely scenario is going to be some version of mobile health clinics, telehealth usage, as well as consolidation of services into urban cores with some mixture of those things. That seems to be how we're headed. I think that would have pretty negative effects economically on a lot of these communities, and it's unclear what the health effects would be or how negative those health effects would be.
Sure. Just not exactly the will to save these things right now. And it almost feels in very much the, you don't know what you have till you lose it kind of a thing, but we're the ones forcing it to be lost. So
Exactly.
Thank you so much for being here. I really appreciate it.
Yeah, have a good one.
I want to thank Michael for coming on the show and sharing those insights about a part of the country that a lot of us, if we don't live there, probably don't think a ton about. If you want to know more about his work, I'll have links to that in the description for this episode. And that is it for this episode. Please rate and review the show on whatever podcast app you listen to it on. Like, subscribe, hit the bell for notifications, leave a comment below if you're a watcher on YouTube. Sign up for the Make It Make Sense Substack. Follow me this weekend on social media. I'll likely be out covering some of the No Kings protests here in Detroit in the state of Michigan. And share those on social media. It's Mims News Pod. That's MIMS News Pod, all one word on every platform. I am at Granthermes on Twitter and Bluesky, and at Granthermes TV on everything else. Thank you so much for listening today. I'm Granthermes, and I'll talk to you next week.